My name is Hebert Lamblet. I'm a plastic surgeon. I would like to thank the Vaso family for the opportunity to be with the distinguished guest here. I'm from Rio de Janeiro, Brazil. I also work in Lisbon, Portugal, and I have the pleasure also to be in Albania now at the American Hospital. I have no disclosure, so let's see if it's going to work. Yeah. My experience with adipose tissue started with my practice in plastic surgery more than 25 years ago. So liposuction and fat grafting wasn't is the most common procedure in my practice. And this is a very common question with when we are talking about fat grafting, is the how adipocytes behave and its predictability. So there is a bias, a negative bias of unpredictability in fat grafting, mostly because of the concerns about fat absorption. But when we see patients like this, for example, and we can get this kind of result, there is no other procedure, even when we are doing a facelifting, we cannot achieve this kind of result. And this is the result that we can obtain with a fat grafting. And here was a full face fat grafting. Also, if we look at the skin quality that we can get with the fat grafting and the signaling cells, we see this fat grafting, right? We can see that we can change even scars and fine lines that they are very difficult to obtain with any other procedure. This is because we change histologically the skin for a better, healthier skin basal membrane. And also, we have a change in the collagen bundles because those cells, when they come inside of the tissue, they start signaling and making pathways for the regenerative purpose. In hair restoration, of course, this case, it's a very mild case, but we can get improvement when we do those signaling cells inside of the hair scalp. Here, the same thing. And here you can use hair transplant also, but if you use some kind of regenerative with these signaling cells, we can get this kind of result. But this case, for example, there is no chance for getting a hair transplant. So you need to do something that is really regenerative because this is an immune condition, alopecia areata. And then if we don't use something that is really immunomodulatory, we are not going to get any other result than this one that we got with this fat grafting and signaling cells within. Because we change again the hair scalp and we change the hair shaft as well. This is a Poland syndrome. The patient was born without one of the breast and the muscle in that area, and we just did fat grafting. Not prosthesis, not expander, nothing. Just consecutively fat grafting, 5 sessions of fat grafting in this case, and we could obtain this kind of result. This was a spinocellular carcinoma resection, and you see that she got like some scars inside of the mucosa, and she could barely open her mouth. And just with fat grafting, 50 cc of fat grafting with signaling cells in that area, we could improve the overall aspect. But the most important thing that we released that scar tissue that she had there inside of the mouth. Why? Because we are signaling and immunomodulating the cells and tissue in that area. So predictability is really unpredictable, but unpredictable in my observation in a good way, depending, of course, the surgeon knowledge with the fat grafting, how you collect the fat, how you process your human lipoaspirate, and where you place it. So just for you guys to understand what human lipoaspirate is, this is the canister that since 98, when I start doing liposuction, I leave the canister over the table, sterile during the holding process of the liposuction. This is very common to see that even nowadays, in 2026, you see people leaving the canister down there because they feel like this is garbage. And I had, since I started doing fat grafting, I had a different approach because at that time, I believe this closed environment and the sterile environment would preserve better the fat cells. But in 2001, I was understanding that we were not only transferring fat cells, we were transferring a cluster of cells and tissues, including the signaling cells that we are going to talk about. And 2001 was a landmark in my practice because I could confirm that because I read the work paper of Dr. Zook from UCLA, and I see that she had identified a putative stem cell population within the adipose tissue stroma. In 2002, the same group of Dr. Zook not only proved the mesenchymal orange of those cells, but also its multilineage potential. So cells from the lipoaspirate, cells from the fat that we were collecting from the patient, they have the same mesenchymal stem cells marker as the mesenchymal stem cells from the bone marrow by immunofluorescence and confirmed by flow cytometer analysis. So Dr. Zook took just one cell, one supposed mesenchymal stem cell, and isolated that cell, and then could differentiate this cell in adipogenic, just one cell, in adipogenic tissue, osteogenic tissue, and chondrogenic tissue from the adipose tissue, right? And when this happens, we can call those cells stem cells, right? And this definitely changed the course of the history of fat grafting forever. In 2006, following Dr. Zook protocol, we start doing what we call the chemical dissociation force. That's Dr. Zook at UCLA, and when we were with her there, we published that in 2011. So we were collecting the fat, washing the fat with PBS, and then add collagenate to the process. And then after the digestion of the fat, we have two separate layers. The supranatant, that is the digested adipocytes, and the infranatant, that is the stromovascular fraction that contains all these adipose-derived cells, all the cells that were collected with the lipoaspiration. So we were aspirating this SVF and then centrifuging one more time, and then the final product would be this pellet, that is this red button collection in the tube that we call a pellet, and this contains all the adipose-derived cells, all the cells that we were that contained in this adipose tissue stroma. This includes the red blood cells also, as you can see, it's red, and for laboratory purpose, we use the red blood cell lysine buffer, and then centrifuge one more time, pass through a cell strainer of 100 nanometers, and what that's going to retain cells and debris greater than this, what goes through the strainer has less than 100 nanometers, and then we centrifuge one more time, and then we have this clear pellet that contains all the adipose-derived cells, now without the red cells, and then probably the adipose-derived stem cells is in this white pellet there. But for really state that there is a stem cell there, we need to do the minimal sorting. That's why nowadays we call those cells adipose stromal cells. But then came FDA and said that human cells and tissues and related products needs to be minimum manipulated, homologous use only, and cannot involve any article besides water crystalloids and preserving agents. So if you are using, for example, collagenase in your process, you are regulated as a biological product, and you cannot use this in humans. That's why we, in 2008, we're trying to find a solution to this regulatory issue. We start doing what we call the mechanical dissociation protocol that has two parts. That's the first part, the shear force transpasser. We are connecting two syringes and passing this adipose stroma through this syringe in this transpasser, and then we are going to get a dissociation of those cells without the use of the collagenase. So that's what, when we present this in 2011 in Miami at IFET. And the second part of the protocol is the pellet collection, as we did on the chemical. And then we get this final product that is the pellet containing also the red blood cells that it's totally fine. This is our first master's degree at Federal University of São Paulo, and this thesis is well documented there. So in 2008, already, from 100 mL of human lipoaspirate, we could isolate 40 to 50 million mesenchymal stem cells with the mechanical process and 30 to 40 millions with the chemical. That was already a great achievement. And we were doing the minimal sorting, of course, CD45 negative, 31 negative, and 34 positive. And we were also expanding those cells in the lab to show the confluence of the cells. And then we could conclude that the mechanical method is much, much better because it's practical, minimal manipulation, homologous, preserve 100% of the adipose derived cells because it's closed. We were using a system that is totally closed. We are not losing anything from there. And also, these also can retain the related cytokines and the signaling cells. We're seeing the same product there inside. It's collagenase free and free of charge. But the most important thing is because we can use this in humans because it does not contain any other product that is harmed to the patient. But then came Aronovitz in 2015 and said the enzymatic methods still have more nucleated cells with a higher number of progenitor cells compared to the mechanical. But this is because since Romanov in 2005, all the mechanical techniques were based on simply washing, vibrating, shaking, filtration, associated or not to centrifugation of the lipoaspirate. This is effective to isolate the ASCs, but not enough to compare with the chemical dissociation, because we know that the adipocytes has a strong binding force with the collagen extracellular matrix. And if we don't use a strong shear force, we cannot break up this extracellular matrix and release these adipocytes, these adipose-derived cells from the adipose tissue cluster. But the beauty of the mechanical dissociation force is when, like I said, when you liberate these entrapped cells from the adipose tissue stroma, we are going to release and retain all these signaling cells, tons of growth factors and cytokines that are signaling cells, and promote healing and repair through these multiply mechanisms that we cannot go through here because of the time. And the interesting also is that the composition of this pellet is just 5 to 10% of adipose-derived stem cells. 30 to 40% are immunomodulatory cells, monocytes and macrophages. That's why those cells has an important and dramatic immune response regulation. That's why Kaplan in 2017 says that because of this paracrine effect, because of this signaling effect, the appropriate label for those cells would be not stem cells, but mesenchymal stromal cells or medicinal signaling cells. And nowadays we can see those cells through the nanolife technology. Just in 2024, we could see this, right? That says mesenchymal stem cells from the adipose tissue stroma. And also these cells being undergoing mitosis. And this is just possible because of nanolife technologies like 2-3 years ago. So tissue regulation needs essentially the right cells to do the job, the environment such as scaffold to support the cells, and the right biomolecules and growth factors to make those cells healthier and productive. Physical and mechanical force to influence the development of those cells in the neighborhood that you are injecting those cells. In 2021, we did the second master's degree at Federal University of São Paulo with the team of innovation technology from the fat obtained in plastic surgery. This was published and it's open source, so you can check there in 2022. This talks basically of the challenge of the 21st century, that is the technological disruption. We are living this, the climate change, the nuclear weapon, this is globally. In medicine, we are living this also, that this challenge, our challenge in medicine is the technological disruption, the Internet of Things, big data, blockchain, telemedicine, and biotechnology. In plastic surgery, the technological disruption is the biotechnology, highlighted by the 3D printing bioengineering scaffolds. So just for you to understand this, endothelial cells from the umbilical vein, when associated with exosomes from the adipose-derived stem cell, can in vitro produce a perfect tube formation and migration in this matrigel mode. When we bring those cells to our in vivo animal mode, we add those cells to our fat grafting, and we are going to transplant this to the animal. In the case, it was an animal mode. And these cells in that environment are going to start signaling and produce neovascularization and immunomodulation that ultimately are going to have, we are going to have a better retention of this grafting that we are putting there. And this is what we call DECM Bio Inc. This is encapsulating live stem cells from the encapsulating live stem cells are incorporated to this decellularizer extracellular matrix tissue and plated in a 3D printing polymeric framework, layer by layer, followed by gelation, is going to make a perfect 3D gel structure that can be used for many options like tissue engineering, drug screening, and in vitro disease model. This is what we call melt electrowriting microscope 3D printing model of 100 nanometers. Spheroids are embedded in agarose and plated with crown stem cells in this macro scaffold. And then we see in the scanning electron microscopic image the perfect integration of these spheroids to the micro scaffold. And down here we can see the macro view of this 1.2 centimeter scaffold with these spheroids, and the micro view showing the perfect integration of that. In the perspectives of the future, the 3D print, we still want to highlight the 3D printing by engineering scaffolds, but in the near future, what we are going to see is like cells and tissues being delivered directly to your hospitals and clinics. But surgeons who manipulate fat are fortunate because they have the perfect 3D scaffold. They just need to incorporate these live cells to the collected human lipoaspirate. And in 2025, last year, we published the second important article on this that's called WISE, that is a systematic mechanical protocol for maximizing the therapeutic yield from human lipoaspirate. And believe me, it has like large volumes and small volumes, pathways. And believe me, still nowadays, we publish this, and there is still people that are really discarding a lot of good products from the human lipoaspirate, and we are not going to concentrate on this because we don't have time. So regeneration is not a cell, it's a moment. More cell is equal to more regeneration, maybe, but the important thing is the ecosystem of regenerated products and subproducts preserved and transferred in synchrony to the patient to get the signaling aspect of the regeneration. And if cells disappear, why does healing continue? Because regeneration is driven by signaling, not replacement. And fortunately, we are going to have other opportunities to show more about the WISE and how it can change completely the scenario of the signaling and the regenerative medicine purpose. Thank you very much.